Hi, this is Dr. Bhargava. This is the next set of cases from Body Imaging Case Review series. This is our first patient. We have performed a CT of the abdomen and pelvis, and on the axial image we find that the liver has a nodular contour consistent with cirrhosis, also seen here. This patient also has large volume ascites in the abdomen and pelvis, and some of this fluid is projecting out here from the abdominal hernia at the umbilicus, and some of it is going down into the scrotum. And so this is a good example of how the herniated ascitic fluid in the umbilical hernia looks like, and also that the processus vaginalis can be patent, or sometimes the fluid can push through the processus vaginalis to go into tunica vaginalis and become large hydrocele when there is ascites. This is our next case. Here we are looking at a single image in a planar projection from a 3D acquisition which was performed as a part of MR urogram. And so when we want to opacify the collecting system ureters and the urinary bladder, we have two choices. Either we can use the T2 signal and do it the way it is shown here, where the technique is similar to MRCP, and the images are heavily T2 weighted, because of which anything fluid is very bright and anything not fluid is very dark. And you can do a 3D acquisition and look at rotating images to evaluate if there are any filling defects in the collecting system ureters or the urinary bladder. The second way this can be performed is similar to CT urogram, where after giving gadolinium contrast, we acquire delayed images and wait for kidneys to excrete the contrast into the collecting system ureters and the urinary bladder, and then do a post-contrast acquisition. So this is an image from an MR urogram, typically performed when a CT urogram cannot be performed for reasons such as renal insufficiency, or patient is allergic to the iodinated contrast. This is our next patient, and here the abnormal finding on this single axial T1 weighted fat saturated post contrast image is in the pancreas. So this is the head of the pancreas, and inside the head of the pancreas you see a loop of bowel. You see the bowel signature. There is this luminal, there's a focus which has a lumen, and this is the second portion of the duodenum, and so the pancreas goes around all the way around the duodenum, and that would make this an annular pancreas. These patients can present with signs and symptoms of gastric outlet obstruction. All right, this is our next patient, and we are looking at multiple images from the MR of the abdomen. The coronal T2 weighted image shows these multiple T2 hyperintense foci in the wall of the gallbladder, and we see the similar finding here on the T1 weighted fat saturated image before administration of contrast, and we find that these are bright. These foci that are arranged in the wall of the gallbladder. Here is how they look on the MRCP image, and this is post-contrast image showing that there is no enhancement. And so this finding is benign. It's called gallbladder adenomyomatosis, and this is its characteristic appearance on MRI of the abdomen. This is our next patient, and we are looking at their ultrasound of the kidneys several years apart. I was reading this study where the kidneys are atrophic, the cortex is thin and hyperechoic, because of which the pyramids are very prominent, and there is expansion of the renal sinus fat. It's seen in the right kidney and also in the left kidney. And when I went back in history in their record to find a prior renal scan, I found a more normally looking kidney where the size is normal, the renal sinus fat is normal in size, and the cortical thickness and echogenicity is within normal limits bilaterally. So this is a good example of how a normal kidney changes when there is medical renal disease, let's say from high blood pressure or diabetes, and becomes smaller with atrophy of the cortex and expansion or enlargement of the renal sinus fat. This is our next patient, and these images are from a CT urogram showing characteristic appearance of a urinary bladder malignancy or a urothelial or transitional cell cancer. And so as a part of this scan, we acquire images without contrast. And so this is the axial image showing this tumor that's arising from the left posterolateral wall of the urinary bladder going into the lumen. Sometimes there are surface calcifications. Those are also characteristic of those tumors. And on delayed images, when the kidneys have excreted the iodinated contrast into the bladder, these tumors are seen as a filling defect. And so remember, when there is such a tumor, the entire tract from the collecting system to ureters have to be interrogated thoroughly and bilaterally, because these patients can have multiple urothelial tumors along the urothelium. And so this is another view, the coronal, showing the filling defect arising from the bladder, and here is the sagittal image of the same. Sometimes we are able to find with advanced tumors extension beyond the urinary bladder wall and presence of obturator and pelvic lymph nodes, and so that can be seen in advanced and metastatic disease. Usually these patients get an MR of the pelvis for better evaluation of whether there is tumor invasion through the urinary bladder wall. This is our next patient, and their abnormal finding is in the spleen. Otherwise, we see a cirrhotic liver and a moderate to large volume ascites. In the spleen, we see this T2 hyperintense focus, which has been evaluated further on these contrast enhanced images. At the bottom, I want to draw your attention to this fat saturated T2 weighted image, which shows that the signal did not drop. That means that this lesion does not have fat. And so on the post contrast images, we find that this is a low T1 signal and shows peripheral nodular enhancement and centripetal fill in, and these findings are consistent with a hemangioma. Here's our next patient, and the finding was incidental on their CT of the abdomen and pelvis. We find that part of the pelvis is outside the field of view, and there is descent of the pelvic floor. We find that there are fat or mesenteric fat and small bowels extending from the pelvis inferiorly. We usually draw this line from the inferior aspect of the pubic symphysis to the tip of the coccyx. It's called the pubococcygeal line, and anything inferior to that is abnormal. And so we find that a portion of the urinary bladder has descended into the pelvis, and it has dragged with it the UBJ, because of which we find that there is a left-sided hydronephrosis. Here again, we see the urinary bladder outside of the pelvis inferiorly. Here is our next patient, and we have some images from a MR of the abdomen and pelvis. The image in the center is from the CT scan, and on this coronal image we find that liver is dark, spleen is darker, and spleen is enlarged. And here on the left we have a in-phase image and an out-of-phase image. This at the bottom is an out-of-phase image because we see this India ink artifact, the dark line along the organs, and so there is signal increase from in to out-of-phase images. And we know that signal decrease is from hepatic steatosis or fat infiltration. Signal increase, like we see here, is from iron deposition. And because of iron deposition, we see this darkness here in the liver and also in the spleen. Usually, when there is iron deposition, the liver is hyperdense on CT compared to the spleen. That finding is not very characteristic in this patient, but the MR features that I just described are. And so this patient's liver has iron deposition. Here's our next patient. They presented with abdominal pain. They were found to have sigmoid diverticulitis. And look at the way this inflamed sigmoid colon is abutting the urinary bladder. And there is all of this is probably granulation tissue, and there is focus of air extending from the lumen outside, protruding towards the urinary bladder, and there is some non-dependent air in the urinary bladder also seen here. And we see that this is the part that is trying to find its way out through the bladder, and so this should be reported as a developing colovesical fistula secondary to diverticulitis. Here's our next patient, and this is a scout image from their CT showing this linear foci of calcifications throughout the intra abdominal cavity, and these foci of calcifications look like this on the axial, coronal, and sagittal images. These foci of calcifications are linear, they're involving the peritoneum, and there is a free fluid that is also seen in between the bowel loops and these foci of calcifications. This entity is called encapsulating peritoneal sclerosis. This can be seen, is rare, and can be seen after long-standing peritoneal dialysis in patients who have chronic kidney disease. Patients can present with bowel obstruction, and the prognosis is not very good. Okay, so moving on to our next patient. This patient was diagnosed with head and neck cancer, and we performed a FDG PET-CT scan for their staging, and we see the primary in the region of the left tonsil and then adjacent hypermetabolic lymph nodes in the left side of the neck. There is also this focus that is seen in the liver, and so that's their primary in the left tonsil. These are hypermetabolic level 2 left-sided metastatic lymph nodes, and that's the focus in the liver that we initially thought could be metastatic disease from the head and neck cancer. They received chemoradiation, and we performed a follow-up FDG PET-CT scan, and here's the follow-up study showing a good response. The primary is not seen as a hypermetabolic focus, and the metastatic disease hypermetabolism that we saw previously has also completely resolved. But what's interesting is that this focus in the liver remains. And so this was interrogated further, and we found that on the PET-CT images that we were initially evaluating and thought that this was in the liver, it's actually not in the liver. And it seems that way because there is misregistration between the PET and the CT. On the PET-CT, on the contrast-enhanced CT images, it is an enhancing focus in the gallbladder, also seen here. And the patient underwent cholecystectomy, and we found intracholecystic papillary neoplasm. All right, moving on to our next patient. They presented with abdominal pain, and we find that on this axial image from the CT of the abdomen and pelvis, they have non-dependent air in the bladder. They have foci of air in the wall of the bladder, so they probably have emphysematous cystitis. Also, they have bilateral hydronephrosis. There is perinephric fat stranding, so maybe there is some ascending infection going on there. And look at the appearance of the bladder here on the sagittal image, sort of tapering like that towards the urethra, and that tells us that the prostate is missing, or they've had a prostatectomy and vesico-urethral anastomosis. That may have predisposed this patient to ascending infection, which is what we see here as signs of emphysematous cystitis. Okay, moving on to our next patient. This is a young female who had a MRI of the pelvis for abdominal pain and distension. And on the top, we are looking at T2 weighted images in a small field of view in all three planes. Axial image showing these large foci, one on each side of low signal intensity. And this is where the uterus and the endometrium are. Here's the urinary bladder on the sagittal image. And then here's the coronal image showing those two findings. On the T1 weighted image, we have high signal intensity. On fat saturated images, we don't see any signal drop. And on post contrast images, enhanced images, there is no enhancement. And so these are cystic lesions that contain blood. And that's why there is T1 brightness, and also there is restricted diffusion as seen here with bright signal on DWI, low signal on ADC. And so this patient has bilateral endometriomas. T2 shading is a feature that is commonly seen in these lesions, but here we don't see that in our patient. This is our next patient, and this was an incidental finding on a CT of the abdomen and pelvis without contrast. Look at the kidneys bilaterally. On the axial and the coronal image, we find that there are calcifications in the medullary pyramids bilaterally in a symmetric fashion, and this is characteristic for medullary nephrocalcinosis. Here's our next patient. We performed a ultrasound of the right upper quadrant for right upper quadrant abdominal pain, and what we found were these large hyperechoic masses of different sizes in both lobes of the liver. And so when you see something like this, you have to raise the concern that this patient has metastatic disease. And so it turns out that this patient has metastatic neuroendocrine tumor, and this patient also had a follow-up FDG PET-CT study where on this planar or frontal MIP image, we find that the liver is enlarged and it is full of these large tumors that are FDG avid. And because this neuroendocrine tumor is FDG avid, it's probably a high-grade tumor. And that's the clinical situation in which they do not take up dotatate, but they preferentially take up FDG. And they are so hypermetabolic that they're drawing this glucose away from the brain. We see less intense uptake in the brain compared to the liver. This is our next patient. An interesting finding here. They presented to the ER with pain and swelling of the penis, and the CT of the pelvis was acquired to evaluate that. And we see that there is a lot of subcutaneous edema in the penis, and so that's the hypodensity is all the fluid and edema. And here the part that is enhancing is the corpus corpora cavernosa. Corpus spongiosum would be somewhere more posteriorly. And what we find is that there is this hyperdense focus that is around the penis, also seen here and here. And on further evaluation, it turns out that they put a rubber band on their penis. They did not know when. And one morning they woke up with severe pain and swelling of the penis, and that's how they presented to the ER. Obviously, the symptoms resolved when this rubber band was taken off. This is our next patient. They came in with abdominal pain. We performed a CT of the abdomen and pelvis. On the SCOUT image, this is a practice that I have, and I tell my trainees to always look at the SCOUT image to evaluate for stool burden and to better evaluate anything that is hyperdense, such as coils, calcifications, bullet fragments, things like that. And so here we can see that the colon is just full of stools, and in the pelvis we find that that's a sigmoid colon which is full of stools. And as the stools stay longer in the body, they become more hyperdense, as seen here, and they incite an inflammatory response, because of which there is mural thickening and enhancement. There can be fat stranding also, suggesting stercoral colitis from chronic constipation. Okay, incidental finding in our next patient, we see appendectomy, clips in the right lower quadrant, and one of those clips has moved to the subdiaphragmatic location. And so remember that when we put clips for, let's say, tubal ligation, appendectomy, cholecystectomy, these can come off from where they were initially placed, and then they can travel in the intraperitoneal compartment. Usually they will descend to the most dependent portion, like the recto-uterine pouch of Douglas, and then just stay there. Sometimes they can move to a location such as a subdiaphragmatic location, like we see in this patient, and then they just stay there to be seen incidentally on future imaging. All right, so here we have an X-ray where we see this large X-ray chest, where we see this large opacity overlapping with the cardiac silhouette, and this opacity has an air fluid level, suggesting that this is a part of bowel that is in the chest, so a large hiatal hernia. And this one is a good correlation between what we see on the chest X-ray and the CT. Here is their CT showing most of their stomach is in the chest, and also seen here, and that's the air fluid level, and that's the finding that is seen posteriorly, large hiatal hernia with most of the stomach in the chest. Thank you for watching.